Good afternoon, ladies and gentlemen, and welcome. And we're going to change this to Lunch and Learn, okay? Because so many people call up and say, well, does lunch go with that? Yes. So maybe we'll just change it to Lunch and Learn. Today we're going to be taking up a very interesting topic that impacts all of us.
We've lost your mic. We've lost your mic.
Have you got it?
We lost the mic.
Have you got it? No?
Turn the mic off?
You have me turned off someplace else.
Testing.
What can I say? We're not professionals. We're passionate volunteers.
Testing. I was working 5 minutes ago. Hold on.
Well, while he's doing that, I'll just elevate my voice and we'll talk about a few other things. Number one, I'd like to invite each and every one of you to consider joining Leaders with Vision. We have an organization that will take on any topic. There are no borders to our discussion except for being nonpartisan. Okay?
Try your mic.
Is that it? That's it. Okay. So we invite you to join us as we try to improve, inform, and become a more inclusive community, not just here, but the community of Baton Rouge, the state, and the nation. It is through your support as members and attending our luncheons that we are able to make these programs available on social media. The one thing that you do have by coming to the luncheons is you have the ability to go beyond the message that they came to tell you today. Because after the first half an hour, the program will switch to questions from the audience. On each table you will find cards. If you will write out your questions and send them up, we will get to them as soon as we finish with our program. To the members, we will be having a session, a meeting in June shortly after the Reality Check luncheon. The Reality Check luncheon is on the 3rd of June. It will be a legislative review of what they just did to or for the people of the state of Louisiana. You will have great representation. We have John McGinnis, we have the Clerk of the House, we have the Secretary of the Senate, and we have PAR. We are also trying to get the minority report from Dr. Albert Samuels and possibly inviting Jim Inkster if he can work it into his schedule. So you have a variety of views, but that's just the way we do business, okay? And again, you will be able to ask them questions. As I was saying, we will be setting up a meeting to meet with the members and start on committee assignments because we want to become more proactive now that we have gone through the initial phases, and I'm happy to tell all of you that we got all of our paperwork in yesterday from the IRS, and we are a solid 501c3 and we have a 501c4 educational foundation, so we are thrilled to announce that. Okay, it's been a while, but we got it done. Now, as we start today, we're going to start to my right, okay, stage left, and start with Don? No. Jerry. We're going to start with Jerry Phillips, who is the LSU advisor, and he will start our program off. Jerry? And see the man that's standing up back there. He'll tell you when your 5 minutes is up.
Great.
Afternoon. Appreciate the opportunity to come here, see some familiar faces and all that. It's good to see y'all. Just a quick background since I got 5 minutes. Today's topic is on the privatization. Just for a timeline for you, July 1 of 2012, there were 10 state acute hospitals owned and operated by LSU. July 1 of 2014, 2 years later, there'll be there'll be 7 owned state hospitals that are operated by private entities not operated by the state. 3 hospitals will have closed. 2's already closed. EA Conway, Earl K. Long in Baton Rouge closed last spring, April of last year. W.O. Moss over in Lake Charles closed last June 23rd. And this year, Huey P. Long will close. So in Baton Rouge, you got the lake that's operating the Safety Net Educational Facility. In Lake Charles, you got Lake Charles Memorial. And as with all of them, the deals are a little different. In Alexandria, you got Christus and HCA through Repeats operating that charity net system for the uninsured. The other 7 hospitals are operated by privates. In New Orleans, you got Lake Children's. Over in Bogalusa, you've got the Lady of Angels through the Franciscans. Lafayette, you got Lafayette General. In Houma, you've got a partnership of Terrebonne General and Ochsner. And of course, as I mentioned, Lake Charles, you got Lake Charles Memorial. And up in EA over in Conway and then Monroe and Shreveport, you've got Shreveport, both of the Shreveport Hospital and the EA Conway hospitals operated by the foundation in Shreveport. So as the deals went through, there are lease payments that are monetized. The assets that allow the private entity to operate the facility. By state constitution, the state cannot just give something to someone to operate. So had to use a fair market value system that was negotiated between appraisers for LSU and appraisers for the private entities to come up with a fair market value. And as some speakers get into, advance payment was part of that fair market value, but it was all part of one fair market value. For example, at the market value in Lafayette is $170 million over 10 years. If Lafayette General paid $17 million up front, that's basically 10%, which I understand was a commercial allowable amount. So you'll hear more discussions about the advanced lease payments. On the Medicaid funding, which I was involved in when I was DHH Undersecretary, that's where the normal process that was in place for paying the state hospital, state-owned and operated, now state-owned and private operated, was still uninsured. We pay them the uninsured through what's called the disproportionate share hospital program. So that continues to go through. You've probably read and heard a lot of discussion about the state plan amendment. That's the bureaucratic way that the agreement between the federal government and the state occurs, is through these state plan amendments. And you've read a lot of that and where that discussions are, and DHH probably can give you some updates on where we're at with those discussions. On the private side, there's been discussions about these UPLs. Again, that's a normal thing. The state DHH does lots of UPLs, and it's really nothing out of the ordinary. What's really been at discussion with CMS has been those advanced lease payments. And again, there'll be some updates, I'm sure, on that. So that's the background where we're at. You had 2 years ago, you had 10 state-owned, 10 state-operated facilities. July 1, 2 years later, you'll have 7 owned state facilities. Those 7 will be operated by private entities. 3 have closed entirely and are now those clients are being provided by another private entity. The information that we received is that for patient care, the actual reason for the system, the reason for the payments appear to be going very well, that the patients are receiving the care, receiving more care and more availability of care than any time before. In a lot of the areas like Alexandria, Lake Charles, a lot of the patients that had any kind of specialty requirements were sent to Shreveport and New Orleans. Now, except for some very specialized services that's provided in the community. Graduate medical education, the residents now have a much more wide range of places to do the training and to have more opportunities for a volume of patients instead of the reduced patients that were before. So that's the background where we're at. I think next is Don. Are you next? Or?
Yes, sir. Thanks, Jerry. Don Gregorio, former Medicaid director under Jerry Phillips and under David Hood. And worked for or with almost everyone on this panel at one time or another. It's a remarkable panel you have here this morning, with possible my exception. It's a pleasure to be here. I have gone to work for the Public Affairs Research Council as their healthcare advisor. And when this privatization of the LSU hospitals arose, PAR took a look at what was going on with the hospitals and produced a report that's on their website. And I encourage you to look at it if you have not had a chance to see it. It's a fairly good synopsis of what occurred. It gives a little bit of background of LSU and what they historically did. It follows the transition process, if you will, to the new private partners. It does a fairly good job of following the money that used to be flowed to the LSU public hospitals and now flows to the private partners. It talks about the financing of the new hospital arrangements, the strengths and the weaknesses in that. And it talks about what PAR would like to see in the long term in regard to quality indicators, outcome measures, and things that show that the new partnerships are producing results that we all hope that they will, and we want to see articulated in reports to the public. So don't be scared by the size of the report. There's about a 2-page executive summary you could read that would give you a real good overview of the report. The report contains a section that breaks out each individual hospital because they're all unique, and these partnership arrangements are unique. They're not cookie cutter. So the one here in Baton Rouge is different from the one in Shreveport. So it gives you a kind of a synopsis of the different arrangements that the state has arrived at because the hospitals were different and the populations they served were somewhat different. And so it gives you a chance to get a real local flavor, if you will, of what each partnership looks like in that regard. But what I would like to do is take you back to 1998, if we can. 1/3 of the children in this state in 1998 were uninsured. We were number 3 in the nation for the number of uninsured children. David Hood was a big part of changing that landscape. We embraced the CHIP program, which is part of the national CHIP program, for expanding coverage for insurance for children. We moved over the last 16 years from that 3rd to the worst in the nation for insuring kids to the point where now only 3.5% of our children are uninsured, and we're probably in the top 5. It depends on whose numbers you look at. Probably in the top 5. We're surely in the top 10 states in the nation for insuring kids. That's a remarkable turnaround for a poor southern state to move from so low to where you're the 3rd the worst, where we always get compared to Alabama and Mississippi as being at the very bottom of almost any healthcare list, to where we get compared to Hawaii and New Hampshire and states that we hardly ever get compared favorably to, and we are when it comes to insuring children. Now, that kind of moves the discussion to adults because we haven't done the same thing for adults in our state. It depends on who you look at or whose numbers you look at. The uninsured rate for adults between 19 and 64 in our state, probably somewhere in the mid-20s, anywhere from 23 to 28, 29% of our adults are uninsured. If you look at those below 200% of the federal poverty level, the number goes way up. It's near 1/3 of those adults are uninsured. So it compares to where the kids were back in 1998. And so what we have had is a big policy debate about where we move to cover those uninsured adults. Do we do it through a Medicaid expansion, which we could through national health care legislation that was passed by Congress? It's our option. Or do we do it through the LSU safety net system? And the political decision, at least to date, has been that we will reinvent the LSU hospital safety net system, and that's where those uninsured adults that don't have access to care anywhere else will receive their care. It's an ongoing debate. The administration will tell you that they're concerned about the long-term cost and other things involved with a Medicaid expansion, and that's the reason they've shied away from doing that and have instead opted to embrace this reinvented LSU safety net system in lieu of that. There are some very good early results being reported out of the new partnerships. Services are being restored, wait times are down. We want to see that early results continue. My time's up. I've run through my 5 minutes. I'm sorry, but I'll wrap this up really quickly. And so PAR will continue to watch and observe this transition of this safety net system and look for those positive outcomes that we all want to see. Sean?
I'm just listening to Dean in his bill.
All right. Thank you very much. And it's an honor to be here with people who've been involved in this issue a lot longer than I have. But I'm just going to talk a little bit about how the Budget Project sees the world, the Louisiana Budget Project, and looks at this privatization issue. First of all, I mean, there's been a lot of talk about this being real reform, and I guess the way we look at it is, as Don alluded to, what the state has really done over the last few years with this privatization of the charity hospitals is really try to double down on a model that's been in place in Louisiana since the 1930s, which is this idea that instead of covering people with an insurance card, we're going to funnel money to a select set of hospitals, to some buildings, and those buildings, those hospitals, whether they're owned by the state or now managed by private entities, is where you go if you don't have an insurance card. And if you have an insurance card, you go to any doctor or hospital that will take you. So that's been the model in Louisiana long before Governor Jindal got here, and that's still the model, and the model that we've been trying to sustain now for the last few years. When money ran short during the Great Recession and the state started having budget problems, like every state, Louisiana looked for some creative ways to continue filling these gaps. And one way they did it was through the privatization efforts of the charity hospitals, and they got $280 million in upfront lease payments in order to fill those gaps. And that was a way to kind of keep the safety net model going without having to put up extra state cash to draw down that federal money that sustains these buildings that where the uninsured get cared. And the other way was through these UPL arrangements. And there's probably about maybe 24 people at most in Louisiana who truly understand the UPL arrangements. Probably 3 or 4 of them are sitting right here beside me, but it's a very complex Rube Goldberg scheme for essentially reducing what the state pays and drawing down extra federal dollars that then go to a select set of hospitals with essentially no strings attached. So that's how the state has gotten through its financial problems that for the past 4 years, through the UPL program and the upfront lease payments associated with privatization. Well, in the last month, the federal government has really blown the whistle on both of these arrangements. You saw the denial of the state plan amendment to do the privatization, and then last week the CMS, the same agency, sent a 6-page letter that doesn't mention Louisiana by name, but essentially says that these UPL arrangements, this Rube Goldberg structure that we've created, and other states as well, Texas has done it too, is not going to be sustainable for the long run. So I don't know, I'm not party to these negotiations, of course. I don't know how this is going to end up, what the state will end up having to pay, or when that payment will be due. That's subject to appeals and a bureaucratic process. But I think what's clear from the last couple of weeks is that this model is clearly not sustainable. This safety net model that we've been trying to prop up with these very creative financing arrangements can't continue into the future. So either this governor or the next governor is either going to have to do one of two things. They're going to have to find new state dollars to put into this safety net, because you're not going to be able to do these same arrangements, or you're going to have to move to a model that covers people. And fortunately, there is a model out there that covers people, particularly people under 138% of the federal poverty level who could get a Medicaid card. And what we've learned about Medicaid expansion, we're now 8 years out from the first iteration of Obamacare. It was in Massachusetts under Mitt Romney, which was the first state that basically said everybody has to carry insurance. And what we've learned in the last month or so, a study came out and they've looked at this, and you know, we can talk about all kinds of health indicators, and we can talk about, and I think there are some very good things that have happened under this privatized model. There is more specialty care, there is better care in some cases being delivered in these hospitals, but the ultimate health indicator is whether you're alive or you're dead. And death rates in Massachusetts have gone down as a result of people getting coverage. And that's not really a big surprise. You know, this governor has dug in his heels. He has his reasons, and he's made those clear. But this problem is not going away, and it's not going to be solved with a speech. And it may not fall to this governor, but either this governor or the next governor is going to have to deal with his financing problems because, again, the federal government has said that the way we're doing things is unsustainable. Did I hear a bell? I think I heard a bell.
Thank you. And I want to thank Leaders Division and Gene for inviting me to come speak. I'm Calder Lynch with the Department of Health and Hospitals. You know, these are very complicated, complex issues that are often emotional for people. And so these opportunities to come together and have a really good dialogue with such an esteemed panel, I think are so helpful for our discourse, you know, on these topics. I first want to say that taking us back a step, like Jerry did earlier, to give some context to where we are today, Louisiana has been running a two-tier healthcare system for many generations with the provision of care for the uninsured through the state hospital system operated by the state or, you know, in the last couple decades, LSU. You know, we've been examining that. We've been looking at that long before national healthcare reform. There were reports, lots of policy folks weighed in, major healthcare systems weighed in saying this is not sustainable, this is not providing high quality care, or we're seeing diminishing volumes, diminishing quality, more and more state subsidy to keep these running. And, you know, but really never could get the political will to sort of move forward with the reforms that were necessary. And then we were faced in 2012 with Congress's action that in the summer of that year that's very quickly took about nearly $1 billion of federal healthcare financing out of the state system whenever they reduced the matching rate for Medicaid services in Louisiana. And what that really did was it forced us to take a hard look at the way we were providing care and come up with a model that was more sustainable. And as we've had conversations up here that involved you know, the transition of care from those hospitals to private partners through lease arrangements. Those leases were determined by third-party fair market value assessments. All of the payments that had been made to the state for the value of those leases are based on those assessments, and some of those were made in advance. They continue to be ongoing, but all of them total the amount that is assessed as a fair market value. And that's really important because the state certainly has a right to generate revenue from its assets, whether that be through a sale or through a lease. And those revenues come into the state and they come into the general fund. Separately and completely apart from that, we are shifting the financing mechanisms for the care that we provide to that population. For those that are uninsured, we typically call that care uncompensated care or disproportionate share hospital or DSH payments that are made to hospitals that provide that care. Simply put, those state plan amendments that we've been talking about this morning shifted those payments from the public hospital column to the private hospital column. And they didn't even change the total aggregate amount of payments that were made. It was a very straightforward shift. And as a matter of fact, CMS did approve the state plan amendments that govern that mechanism here in Baton Rouge with Our Lady of the Lake, and that agreement also included advanced lease payments. We've had a lot of discussion about what's occurred in the last few weeks, but before I get into that, I do want to highlight what some of the improvements we've seen since transitioning to public-private model. In Baton Rouge, they're seeing over 100,000 patient clinic visits, including 30,000 in North Baton Rouge at the new 24-hour urgent care center. Lafayette has drastically increased its clinic capacity, reopening previously shuttered clinics, including a pediatric clinic, a medical detox unit, and an orthopedics unit. New Orleans has increased its emergency department capacity, reopened 9 inpatient psychiatric beds. Lake Charles Memorial with Moss has opened up new services, a new urgent care center. Physicians have tripled their throughput of patients per day. We are seeing enormous new improvements in reductions in wait times and backlogs, opening new services. It's really been very positive for the patients across the state. And now in terms of the CMS disapproval of the pending state plan amendments for 6 of the partnership agreements, We've had several conversations with CMS since then, most recently yesterday. It was a very productive, very positive call. CMS provided excellent leadership and a very clear path for the state forward. They re-emphasized that the public-private partnership model is, we can continue on that path. They support the mission that we've laid out through that model. And they provided a path forward that involves immediate submission of new state plan amendments that clarify some of their concerns. The state plan amendments will focus solely on the reimbursement methodology for that care, for that those uncompensated care payments. They have expressed that doing so will resolve some of those issues that are remaining, and that we can move forward in a way that will continue to provide the payments for the care that's being delivered through those agreements across the state. I hear the bell, and I'm sure we'll have more questions about that, but the bottom line is that we have a very clear path forward from CMS that they believe is sustainable for the state through the public-private partnership model.
Well, it's good to have privatization on the menu here, and at least here I have a possibility of winning the argument about privatization. Diane, my wife, and I, we argue this out quite often, and I mean, I'm a guy, I can't win when I get an argument with my wife. I think most of us can understand how that works. So anyway, privatization is something that for the last few years in particular, we've looked at it quite closely and done quite a bit of it. And I'm not sure that we can definitively say that it works or it doesn't work at this point in time, but it won't be long before we will know. Privatization can be good or bad, is my view of it. And sometimes in rich states it works very well. Those with Medicaid programs where they spend vastly big monies, and that's not the case with Louisiana and other poor states, southern states in particular. The reason I'm saying this is because if they're throwing money away in a Medicaid program, if it takes a private contractor to come in, privatize things, and if they can do it for a lower cost, then I think you've got something going that's good, assuming that other things go well as also. I haven't seen that yet here in Louisiana. We do have Bayou Health now for the last 2 years, I guess. And I'm not sure that we have all the data in yet, but we'll see. Don mentioned the Louisiana Children's Health Insurance Program, and yes, we worked on that, put in a lot of hours, making that a success, and you can tell that it is a success. We're one of the best in the nation. We've covered, percentage-wise, many more children, and I think he said 3.5% are uninsured. That's great. I was going to say 5%, which is also great. But we used to have, 30% or so that was uninsured when we started in 1998. And one thing I wanted to tell you, and a little bit of history here, the planning for privatization over about a year and a half before 1998. And in October of 1998, we really got the program going, and we started to enroll children into the Lodgeship program. But prior to that, we had to plan it, and we did a lot of planning, and that planning is successful, or made our program successful. You can't just go into it one day and think you're going to get it right. But the planning originally called for private plans to take care of all those kids. And quite frankly, they ultimately went into the Medicaid program but not into private plans. That was our governor's idea when we were planning in 1997. When I became secretary, I changed that, and our staff came in. They came in 2 at a time, 5 at a time, 10 at a time, saying, we can do this better than a private plan. We know how to do eligibility. We can do it. We have the providers. We can do it. So I said, okay, let's do it. And I think that that has a lot to do with why we are in the top 10 in terms of the Children's Health Insurance Program. This is obviously the hospital privatization is linked very strongly to the privatization, generally speaking, in for example, the Medicaid expansion. Now, we've tried to get this Medicaid expansion across to the governor and the legislature and so on. They don't want any part of it. They don't want it. Now, I've heard Kathy Kleber in testimony at the legislature, and she said that Medicaid is broken, and the governor has a better idea, and that idea is to privatize the charity hospital system, the LSU hospital system. And I'm just almost finished. And I say nonsense. That cannot be a better example. You have 10 hospitals. Are they going to provide better access? No. If you had a Medicaid program where the dollars follow the patient, you can go to a doctor in a rural area where you have no hospital, and your quality maybe could be better, but your cost is surely going up, and that's what we're seeing right now. Thank you.
Thank you, David, and thank you, all of you. I'm glad that you're not candidates, because you would have found it a lot tougher to get past that bell ringing back there. But since we're all interested in the information, and like I said, you're not candidates, we did give a little flexibility to that. Now, while I'm waiting for the cards, does anybody have any questions? Please write them on the cards and raise your hand, and John come pick them up. I want to raise one question. Okay, government is never meant to be in competition with the private enterprise. There are certain services, in fact, government is there to take care of those services that the private enterprise cannot profitably offer. I would say possibly prisons. Why should we be making a profit in that area? Why would we privatize that? And I also asked the question, how can you take a profit out of a hospital and run it more cost efficiently than if you are running it as a public hospital? And I'll take any one of y'all to answer that question.
Well, I think when we talk about privatization in healthcare, it gets a little murky, because really we've operated a private Medicaid program for many decades. Everyone that provides care in our state for the Medicaid population is a private doctor. Most of them were private hospitals, private nurses, that work for private entities. The state's job was really just for paying for it. So, in terms of the LSU system, most of the partners, if not all of them, most are nonprofit entities that we've partnered with. And the notion of profit, whether it's a for-profit or nonprofit or public institution, it's really the same in that it's just margin between your cost and your revenue. And the difference really can be that the cost in a private setting versus a public setting historically can be significantly less due to the ability to better manage staff ratios. I mean, as a public, I can tell you from DHH's experience, when we were operating many institutions, we struggled in terms of staffing costs because we didn't have the flexibility that a private entity had to staff up or staff down, depending on what the patient census looked like because of civil service requirements. We didn't have the flexibility to go out and negotiate augmented services or staff quickly because we were confined by state procurement and contracting laws. Often our wages were above the industry average for that service or field. So there is significant opportunity through privatization to lower the unit cost and improve the efficiency. And certainly, it's not just about profit or nonprofit. Nonprofits take their margin and reinvest it into the community because they're owned by the community. So I think it's a worthy debate to have about our cost structures and our payment structures. But it's more complicated than just saying profit or nonprofit. Anybody else want?
Well, it certainly is more complicated. Again, I would just say that we have history behind us. The lot chip program, again, was very successful. It was done by public employees, and yeah, you're right. We do have a program that is public-private. In other words, the providers in the program are almost exclusively private, except for the LSU hospitals, and now they've been privatized as well. And so the question is, are they going to save us money or not? Are they going to provide better access or not? Are they going to have better quality or not? And one of the reasons that we can't answer that question right now is because transparency has been lacking over the first few years of this privatization effort. It's hard to tell just exactly what the administration is doing. And I wish they would do it differently and let us all see what's going on. That would be very helpful. I remember having a boss once who, I told him that we needed to do a strategic plan. We're doing a lot of things, and what we really need is to tell the people what we're doing so they can get on board, so they can understand. After all, they're taxpayers and citizens. They're the ones that need to know what we're doing. And his response was, he looked at me and he said, why in the world would you want to put a plan out there in the public? Because if you do, it'll take away all your flexibility. They're going to expect that you're going to do exactly what that plan says. And I argued back that, this is government, and it does require a certain level of transparency. By the way, I'm not going to tell you who that person was. You might recognize the name, you might not. But anyway, that was the argument that we were having. And I think that transparency is very important to the success of any endeavor involving government.
Anybody else want to respond to that? John? Not done? Okay. All right, Jan, then I have a question for you. The Massachusetts private insurance plan is being eliminated. What issues developed that led to that decision? By a standard, Massachusetts is a richer population.
I'm not sure I entirely understand the question, but I was not aware that the Massachusetts plan was being eliminated, but what I based my earlier comments on was a study that I think was on the front page of the New York Times that just talked about, 8 years out, the effects on death rates, and that there had been a noticeable decrease. So, but it's true. I mean, there's some of Louisiana's chronic low rankings are not the fault of the healthcare system, and I think a lot of it is due to issues like poverty and obesity and rates of smoking, and there's a lot of factors that the healthcare system can't fix, but there also are things that a good healthcare system can fix, and it's one of the least efficient. We have the most privatized system of healthcare. America does than I think most countries, but we have one of the least efficient. We spend almost twice as much of our GDP on healthcare as most industrialized countries, and our results on a world scale are somewhere, I think, in the mid-30s, right around Cuba or some of these countries that none of us would voluntarily seek healthcare. So there's a real problem in our healthcare system with allocation of resources. That's not something I think you fix at a state level. You fix that at a national level, and different states are experimenting with it in different ways. But from our perspective, if you want a healthier population, it has to start with coverage, and that's why I think Massachusetts is, even though there's a lot of things about Massachusetts, its economy, the wealth of that state, education level, so forth, that are very different from Louisiana, but just the idea that you start with covering everybody and then you figure out how to provide care in the most efficient, rational, cost-effective way. Hopefully that's what Massachusetts can teach Louisiana and other states, and hopefully that's what we're going to get when the ACA plays itself out in a few years and we really get to see the effects. I mean, we're going to have an interesting test case if states like Louisiana dig in their heels on Medicaid expansion. Pretty soon we're going to be able to see what happened in the states that expanded Medicaid and gave everybody below 138% of poverty a health care card and let them go seek care from any willing provider, and what happened in those states that clung to a safety net model. And you know, it's my belief that Louisiana eventually will accept Medicaid expansion, but for now we're not doing it, and there are other mostly southern states, but several other states that aren't doing it, and it's going to be very interesting to be able to compare in a few years how did Louisiana do versus states that decided to move forward with this expansion. I know that probably doesn't answer the original question, but
John mentioned a really important point about inefficiency and so on in our healthcare system. And I just wanted to point out that the Institute of Medicine, which is a national organization, very well thought of organization, and they look into these things. About a year ago, they did an estimate of the inefficiencies in the healthcare system. Keep in mind that we spend somewhere in the neighborhood of $2.5 trillion to $3 trillion per year for health care, way above what any other country spends, even countries that are bigger than us, population-wise and so on. So the fact that we spend that much and we have such a high level of inefficiency and fraud and so on, they looked at 7 or 8 different factors in our healthcare system, and the total there was $785 billion per year in waste, in inefficiencies, fraud, et cetera, too much administration, too many MRIs, too many this, too many that. And so, we need to do something, and if you think it's all in the public sector, you've got another thing coming. It's private and it's public too, but it's $785 billion per year.
I want to add a little to that. I mean, I think David's exactly right. I think that is one of the fundamental problems we face in this country in terms of healthcare is cost. You think about sort of the triangle of healthcare, it's cost, quality, and access. And when you think about what the Affordable Care Act did, it really didn't address 2 of those fundamental pieces of that puzzle, is cost and quality. There were little initiatives here, grants, some efforts around that, but what states were originally mandated to do, and then later the Supreme Court made it optional, was to expand eligibility for Medicaid to a population that previously, in many states, most states, wasn't covered. And so without really addressing any of the issues around the cost of care that we deliver, the efficiency of care that's delivered, and as we've watched over the last several decades in states across the country, Medicaid has consumed an ever-growing share of the state's budget, crowding out other priorities like transportation, education, public safety, infrastructure. And so when you're asking states to take a gamble by adding hundreds of thousands of adults with unknown healthcare needs to their Medicaid rolls without really any additional flexibility to control costs. And that goes beyond just Medicaid. As David said, that's across the entire healthcare system that we need to look at things like defensive medicine, scope of practice. I mean, there's a lot of issues that need addressing to bring cost and quality into the equation, which I think is really one of the fundamental failures of the federal healthcare law.
Why is the Medicaid program growing? Well, for one, to try to cover all the people who are not covered. 15% of our population does not have health insurance, so that's one reason. The other is that the cost of health care is going up like a skyrocket, particularly in the private sector. The higher they go, the higher the rates are and so on, the fewer people have the wherewithal to have private insurance. So they're going to be uninsured, and the uninsured are going to grow unless what? Unless we expand the Medicaid program or a similar program to do that. We desperately need to cover our uninsured population. Citizens and people who pay taxes or don't pay taxes, they have trouble paying that monthly bill for health care, and it's getting worse every year. So Medicaid is growing because the private sector is getting more and more expensive.
Thank you. Now, a question relative to the Shreveport-Monroe area. Citizens of the northern part of the state are concerned about the quality of health care. Taxpayers across the state are concerned about how the contracts were handled and the fact that 50 pages in the contract were what's the word they want to use here? Were empty pages. Could you explain what the people in the northern part of the state can expect in terms of health care? And number two, how's it going to be paid for?
The referral to the missing pages were the cooperative endeavor agreements that are for all the deals. And when the Shreveport privatization was presented to the Board of Supervisors spring of 2013, last year, a year ago, it did have pages that were not completed at that time. Since that time, and when the document went before the Joint Legislative Committee on the Budget in late June, those pages were completed. It is a different model than in the South in that you do not have a private hospital that operates. You got the Biomedical Research Foundation that's the operator of the hospital, both at Shreveport and EA Conway. But there's the same type results we're seeing in the South, far as we have more access to services than previously. The residents are getting good opportunities for their education, so it's not that different a model, except you do not have a private hospital as a partner up there. And those pages have been completed. Now, it's as with ever arrangement or agreement between partners, whether it's private-public or private-private or public-public, whatever the arrangement, there's always, it's a living document, and it's a living arrangement to where as you find things that need to be adjusted, those adjustments occur. So it's continuing to take place in Monroe and in Shreveport, but the feedback LSU is getting, the resident training is above where it was at this time last year, and the patient have more access to local services than they did before.
Thank you. If you have any other questions, please get them into John so that we can wrap this up. I have, next question goes to Calder Lynch and/or Jerry Phillips. Are the privatization plans and money trail open to the same transparency as required on Medicaid? In other words, Freedom of Information Act.
I mean, actually, you can go to DHH's website, and actually, if you go to makingmedicaidbetter.com, and you click on the left-hand side, public-private partnerships, All of the cooperative endeavor agreements and associated documents for each of the agreements are posted online there. They detail the funding methodologies that are used for reimbursement. We also, as part of the Medicaid forecast process, supply to the Joint Legislative Committee on the Budget, and certainly as a public record, an ongoing report regarding the expenses that are being paid out against those cooperative endeavor agreements. And really, there's two fundamental payment mechanisms that are occurring. One is uncompensated care payments or DISH payments to those hospitals based on agreements that are spelled out in those cooperative endeavor agreements. It's, they submit cost reports, they are paid a percentage of that cost in several different cycles. Regarding other payments, there's, in some of the agreements, there's what we call upper payment limit or UPL payments. Those are payments tied to services delivered to Medicaid recipients above and beyond the traditional Medicaid per diem rate that's reimbursed for hospital care. And it's calculated based on the difference between what Medicaid pays and what Medicare would have paid for those services. So it tracks back to, there's a limit. That's why I call it upper payment limit on what you can reimburse, because it's based on the actual patient volume that went through that hospital and the costs associated with those folks if they had been in Medicare. And all of that is certainly available publicly. Okay.
Any other questions? Okay, we're on our final question. Since the Office of Group Benefits was privatized, $1 million a month has been lost. This is unsustainable. How do we know that this won't happen with privatized public health in Louisiana? What oversight has been stipulated to prevent this type of theft/graft? This was a question from the audience I want to point out, and not the viewpoints of this organization. Okay, who wants to take the question?
I can't address the officer benefit side, but what I would address on the Medicaid payment side is that all those provisions have a cap to them so that we know how much can be spent. We have audits of how the money's expended. It's called cost reports in all the deals, and that's required by the feds. We continue it. So really, you've got all the, and there's been a lot of talk about Medicaid expansion. So you have all the parameters for safety of trying to make sure that hospital services are provided through those cost reports. So that's a way to make sure that the costs are identified and paid properly. And two is that the partners cannot exceed a certain cap, or else they have to pay it out of their pocket.
Thank you, David.
Thanks. Well, I'm glad to hear that there's so much transparency all of a sudden. And maybe this is an opportunity for me to ask Calder again something that I asked him about 6 months ago in a Department of Insurance meeting. And we had just watched a slideshow, and one of the slides said that here's what the governor says about the hospital privatization. And so it would be better access, the 3 stars, better access, better quality, and lower cost. And I asked at that time, I'm sure the governor wouldn't say that unless there was some analysis had been done, and there must be a report that shows how much is actually going to be saved. So I never did get it, so I guess that, maybe they were trying to polish up the report, hadn't quite finished it, and then they forgot. So I'll give you the benefit of the doubt, but I would like to see the report that says that it's going to be less cost. That would be very helpful, I think. And maybe the other members of the panel might want to take a look at that too, as well as all the taxpayers, et cetera.
Did you want to say anything, Colin?
Oh, sure.
Yeah, I mean, I have to give you the...
No, I think that when we talk about costs, you look at it in a couple of different ways. I mean, there's the total amount that you spend. There's the per unit cost on delivering services, the number of people you're able to see. I think one thing we do know, and we can clearly show, is that through the partnerships we are serving more people, People are getting prescriptions faster. They are getting appointments quicker. They are having access to additional service. They are not having to travel as far to get those. And we know that we're doing that within the current budget because we haven't added any additional money other than just the natural growth in terms of costs that occur from each budget year to the next. You take into account the fact that you're monetizing a state asset through the lease arrangements that CMS has agreed are appropriate in terms of ability to lease a state asset. They had questions about the advanced lease payments. They clarified that those are not tied directly to the reimbursement that's made to those hospitals. And we continue to answer those questions. Very productive call again this week. We'll be submitting new state plan amendments that clarify that for them. And we believe that we'll be able to move forward on our current track. They reemphasize that. And I think that when you take all of those things into account, your ability to monetize the state assets, what you're spending on care, the number of people you're serving, we certainly are seeing a far more efficient system than we did previously.
Thank you, ladies and gentlemen. Thank you for coming to, so what do we call it now? Lunch while learning. We invite you to become a member of our organization and support the ongoing efforts to educate the public on public policy and how decisions are being made, and to give voice to the citizens. Thank you so much. Our next event will be on the 3rd of June. It is a legislative review of what the legislature just did to or for the people of the state. Please join us. It's our one and only fundraiser. Thank you so much, and watch for our announcement. Goodbye.
I like that.
I didn't know that. I want to put it all in the one document. I think LSU did do a PowerPoint.
John, it's always good to see you.
It's a pleasure. Great report, by the way. Great seeing you. Great seeing you, Eric. Maybe I'll be arguing on yours. Great job. You guys doing anything? Welcome. The latest latest stuff?
Just hanging out here real briefly with Robert, so he would understand as much as I understand.
From what I understand, it's privatized all these.
I mean, we've been kind of
Charity hospitals.
We had a report, we had a draft of a report that's literally,
If they don't have it,
we can figure out what we do still, we read through it, it's like, oh, I was thinking, the same person gonna try to write schematics.
That's when, in fact, when Robert Allison started talking to me about doing this with us.
They're still in there. To what extent?
So, yeah.
That's in
Report that came out about that.
I'm LSU right. Could I see LSU in
That there's these, the whole harmless stuff, they're doing the whole harmless stuff. I don't think they really do, but they could.
basic education to the masses. It's to come.
Yeah.